导播，请问Professor Finnegan 上线了吗？请问导播，John Finnegan 的荧幕会出来吗？好，那我们就开始今天的研讨会。Good morning, ladies and gentlemen. Welcome to the 4th Kp Chen Memorial Lecture. My name is Weijin Li. I'm assistant professor in the Institute of Environmental and Occupational Health Sciences. It is my greatest honor to be today's moderator. On behalf of the organizing committee and the College of Public Health, we sincerely welcome all of you to this historic event. The Kp Chen Memorial Lecture was launched in 2017 and has been generously supported by the Kp Chen Foundation in memory of the founding father of Taiwan's public health education, Professor Chen Gombe. Every year, this lecture is given by a prominent public health leader who has made substantial impact on contemporary public health issues. NTU College of Public Health has been honored to host the conference annually. Today, we're joined by honorable guests affiliated with the Kp Chen Foundation and esteemed faculty members from the college. It is my great pleasure to first invite the chair of the organizing committee, Dean郑守夏, to give the opening remarks.
Dean Finnegan, honored guests, my dear colleagues, ladies and gentlemen. Good morning and good evening to Dean Finnegan in Minnesota. Welcome to the 4th Kp Chen Memorial Lecture. The College of Public Health at National Taiwan University are very honored to co-host with the Kp Preventive Medicine Foundation for this event. And all of you attending today are very much welcome. And according to the legislation and the travel restriction, Dean Finnegan is unable to attend, to come here in person. However, we have well prepared for this event, and I believe this event will be very successful, and we are going to have a wonderful time for this event. Welcome again. Thank you.
Thank you, Dean Chen. Next, it is my honor to invite the chairman of the Kp Chen Preventive Medicine Foundation, Professor Weijin, to give address.
My glass. Dean 郑守夏and Professor Chen, honorable speaker John Finnegan, distinguished guests, and ladies and gentlemen, thank you for coming to this Kp Chen's Memorial Lectureship. And on behalf of Kp Chen Preventive Medicine Foundation, I would like to extend our warmest welcome to Professor John Finnegan to talk about the challenge of academic public health in current COVID-19 and next pandemic. As you may know, Professor Kp Chen graduated from University of Minnesota in 1952. And he is the founder of public health education in Taiwan, and also the pioneer in the public health field work. And today, Professor Finnegan's lecture, I think it's the most meaningful and relevant lecture to the foundation. I wish the lectureship will be successful and fruitful. Thank you.
Thank you, Chairman. Finally, I would like to invite the Executive Director of the Foundation, who is also Professor Chen Gombe's eldest son, Dr. Kp Chen, to say a few words.
Dear Honorable Guest Speaker, Professor John Finnegan, and dear Dean郑守夏, and Professor Chen为坚, and other honorable staff and students. I welcome all of you to attend the 4th Kp Chen Memorial Lecture. 4 years ago, we established Kp Chen Memorial Lecture, which fashioned after Harvard Carter Lecture, to invite world-renowned esteemed scholar to give a talk in an important subject in public health. Through this KP lecture, we hope we can bring new ideas into Taiwan and advance the intellectual academic exchange. It is fitting to invite you, Professor Finnegan, to talk today, since my father obtained the master's degree in public health in 1952 at the University of Minnesota. So it is sort of the homecoming for my father, and he is watching from the heaven. It is also timely for you to talk about the COVID-19, which wreaks havoc on the world health system, and many people are suffering as a result of it. So I welcome you, Professor Finnegan, to Taiwan, my dear Minnesota friend. Thank you.
Thank you, Dr. Conrad Chen. I would also like to take the opportunity to introduce the other directors of the foundation. Professor Chen Wei Jian. Professor Chen is a distinguished investigator and director at the Center for Neuropsychiatric Research in National Health Research Institutes. He is also a distinguished professor in the Department of Public Health and Institute of Epidemiology and Preventive Medicine. From 2011 to 2017, he served as the Dean of College of Public Health at National Taiwan University. Next, we have Professor Zhang Dongliang. He's a professor in the Institute of Health Policy and Management and the former Dean of College of Public Health at National Taiwan University. From 2012 to 2013, Professor Zhang served as the chairman of the Medical Expenditure Negotiation Committee in Taiwan. Finally, we have Professor Zhang Hongren, chairman and CEO of YFY Biotech Management Company. Professor Zhang's past professional experiences include President of Bureau of National Health Insurance, Director General of Center for Disease Control, Director of Bureau of Communicable Disease Control in the Department of Health. Once again, it is our greatest pleasure to be joined by all these distinguished guests for today's event. Today's conference is comprised of 2 sessions, the Kp Chen lecture followed by a discussion session. We are honored to have Professor John Finnegan to give the lecture this year. Dr. Finnegan is a professor and the dean of the School of Public Health at the University of Minnesota, from where he also holds a master and doctoral degree in mass communication. Before starting his journey in public health in 1980, Dr. Finnegan initially followed a career path as a journalist in 1970s. Thereafter, Dr. Finnegan launched a highly successful and exciting career specializing in the role of communication and mass media in leveraging change in health knowledge, behavior, and public policy in the context of community campaigns to improve public health. For his incredible contributions in the field, central to which is a keen focus on socio-economically driven inequities in population exposure to health information. He was honored in 2007 by the American Public Health Association and subsequently the Minnesota Public Health Association's Albert Justice Chelsea Award for a distinguished service to the state's public health in 2012. Dr. Finnegan also has chaired the board of directors of the Association of Schools and Programs of Public Health, ASPPH, from 2013 to 15, and was an original member of ASPPH's task force, framing the future, the second 100 years of public health education. The NTU College of Public Health has been especially privileged through our relationship with Dr. Finnegan. He visited Taiwan in 2013 and served as the chair of the External Accreditation Committee for the college. One amazing coincidence is that up to today, Professor Finnegan and Professor Chen Gombe both served as the deans for 17 years at the University of Minnesota and NTU respectively. In many ways, the college is grateful to be embraced by Dr. Finnegan for his continued friendship in this amazing journey. Let's now welcome Professor John Finnegan to deliver the 4th Kp Chen Memorial Lecture on COVID-19 and Forces Shaping Global Public Health, Challenges for Academic Public Health Before the Next Pandemic.
Thank you. Thank you so much. I hope I can get the screen working here. If you'll give me just a moment, and I will share the screen with you. Let's see here. Okay. Right, let's see if I can get this up. I apologize for the delay here, but hopefully I will be able to get this to go.
It's very exciting to see Professor Finnegan is wearing a pin of the College of Public Health at NTU.
Are you able to see my screen?
Not yet.
Okay, I need to share it then. Let's see here if I can.
While we wait for the slides to be shared, I would like to share with you some stories about Professor Chen Gombe. As mentioned before, he was a founding father of Taiwan's public health education and served as the director of Institute of Public Health at National Taiwan University for 17 years. Under his leadership, the Institute has cultivated many public health professionals, educators, and researchers. In fact, a few of our current faculty members were his students. This formidable force of public health has helped Taiwan to solve many major public health issues, including the identification of arsenic intoxication as the cause of Blackfoot disease, iodization of salt to prevent goiter, and advocacy of national health insurance, eventually leading to its implementation in 1995. The Institute has been expanded to College of Public Health since 1993. Through years of efforts, NTU Public Health has been accredited by Council on Education for Public Health in 2017. It is the first school in Asia, also the first one outside North America. Now, it's once again is of our greatest honor to have Professor John Finnegan to present on the topic this year.
And let me see if I can swap the displays here. And are you able to see my display? Are you able to see the slides?
Oh, yes, now it is here. Thank you very much,
Oh.
Professor Finnegan.
All right, good. Thank you so much. And sorry for the brief delay there. Dean Chang, members of the faculty, staff, students, if you're there, National Taiwan University College of Public Health, and ladies and gentlemen, good morning to all of you. It's an enormous privilege for me to be invited to deliver the Kp Chen lecture for 2021. And in addition to the memory of Dr. Chen, I find myself in the company of some of the best in academic public health today, such as Dean Michelle Williams, who delivered the inaugural lecture in this series in 2017. And I hope to live up to her example and the others before me. As you know, Professor Kp Chen was director of the Institute from 1955 to 1972, and he played a critical role in that generation to build modern academic public health. And I do want to let you know that when he graduated from the University of Minnesota, I was 2 years old. Well, permit me to outline what I want to discuss with you today. And first, I will give you a summary of who I am and where I come from. And I hope that will give you some personal context for my remarks and observations. And as we weigh into the topic that I've chosen, I want to review some of what we all have experienced in the past 24 months. What we have learned about public health successes and failures, and what global leaders think about the challenges that lie ahead before the next pandemic overtakes us. Most importantly for my remarks and our discussion, what should academic public health contribute on a global level that could be most constructive and effective in advance of the next pandemic? So, to start with, I come from Minnesota, which is in the middle of the United States at its northern boundary with Canada. The first humans who came here arrived about 12,000 years ago as the last ice age was ending. They were hunter-gatherers and the ancestors of many of the indigenous people of this region. And the name Minnesota is composed of 3 Dakota Indian words, which translate land where the water reflects the blue sky. And for comparison, Minnesota is about the size of Laos or the United Kingdom. And it is famous for its more than 14,000 freshwater lakes, which do reflect that blue sky when it's not cloudy. I was born in Rochester, Minnesota, which is home of the famous Mayo Clinic, and my mother served there as a medical secretary in the late 1940s, and my father was a journalist on the local newspaper after serving in the U.S. Army in World War II. In 1951, we moved to Minneapolis and St. Paul. And that is, of course, home to the University of Minnesota, where I have worked since 1978. And before pursuing a doctorate, as you heard, I also worked as a journalist in the 70s. I did follow in my father's footsteps until I found public health, or perhaps be better to say that public health in some ways found me. The University of Minnesota itself was founded in 1851. That was 7 years before Minnesota became a state. And some folks say this shows that Minnesota thought that a university was more important to establish first than even a state government. And the university today has campuses both in Minneapolis and on the Mississippi River. and in St. Paul, which houses agriculture and natural resource sciences, biology, veterinary medicine, and experimental farm fields. And there are also 4 other campuses in the different sections of the state, including Rochester, where we have many partnerships with the Mayo Clinic today. And of course, Minneapolis and St. Paul's population, just the metro area, is about 3.7 million, which of course is small by Asian standards. The Twin Cities holds about 65% of the state's total population. Agriculture and food processing are very important to the state's economy and also its largest exports, primarily to Asia, are soybeans, corn, animal feeds, and pork. And iron mining and medical care and manufacturing are also very important to the state's economy. The university was the place where academic public health began in the United States. When the first president was installed in Minnesota in 1869, he said this in his first address. This is a quote. "The time is not distant when a Department of Public Health will be established in all universities." And he took a step in that direction when he appointed this man, Dr. Charles N. Hewitt, as Professor of Public Health in 1873. And that was the first such faculty appointment in any U.S. university. Hewitt's experience as a surgeon in the U.S. Civil War made him an apostle of a radically new approach to health that was just beginning to emerge, germ theory. And later, as Minnesota's first secretary of the State Board of Health, he sailed to Europe to study with Louis Pasteur in France, Robert Koch in Germany, and other germ theory scientists who shared their insights and taught him vaccine production. For many years, public health was taught at the university in a department of the medical school. In 1944, the university's Board of Regents authorized an independent school of public health with Dr. Gaylord Anderson as its founding dean. And he was dean when Dr. Chen was working on his degree at the University of Minnesota. Dr. Anderson completed his medical degree at Dartmouth College and also his doctorate in public health at Harvard University before serving as an officer in the U.S. Army Medical Corps in World War II. So what made our school possible was an endowment that was provided by the estates of Dr. Charles and William Mayo after their deaths in 1939. And to this day, the dean of our school is privileged to award Mayo professorships to our most distinguished faculty. Dr. Anderson is connected to Professor Kp Chen, as I mentioned. They were of the same generation. They both believed deeply in science and research and the importance of converting new knowledge to prevention and health promotion. They understood, they promoted, and they practiced public health in part because they recognized its global scale and scope coming out of 2 world wars. Disease and illness, especially infectious and communicable, recognized no boundaries, whether of nations or socioeconomic class. They understood that public health is both local and global, and that has never been truer than in this century. This is our school today. It includes a regular faculty of 127 and about the same number of adjunct faculty. Also, more than 450 staff and more than 1,400 active graduate and professional students pursuing master's and doctoral degrees. And a large portion of our staff support a research enterprise that makes up about 2/3 of the school's annual revenue, coming mostly from the National Institutes of Health. Since I became dean in 2005, and as of 2020, our total research portfolio has amounted to $1.6 billion US. But more importantly than the amount of funding is what we accomplish in our research. And here are two examples. Our Coordinating Center for Biometric Research is a global trials unit. It is the biometric data hub of a worldwide network of partner sites and scientific collaborators. In 2001, it began working with some of the largest AIDS/HIV prevention trials ever attempted. One of them, the START study, tested the effect of starting early antiretroviral treatment for those HIV positive patients at 2,015 sites in 35 countries. And eventually, that study showed a 53% reduction in serious HIV illness. And in 2014 and 2015, our unit field tested the first Ebola vaccines in Liberia and Sierra Leone. And it is also now following up on a cohort of Ebola survivors looking at the long-range health impact of this hemorrhagic virus. In the COVID pandemic, our professor, Dr. Michael Osterholm, directs the Center for Infectious Disease Research and Policy. That's called CIDRAP. And for more than 20 years, Professor Osterholm was Minnesota's state epidemiologist. So when COVID broke out, he began appearing on major national and global news channels as one of the many experts in the field with a straightforward, no-nonsense approach to clarify public health science, public health research, and of course, prevention for lay audiences. And he also has advised both the Trump and the Biden administrations and various national and international organizations, and of course, the governor of the state of Minnesota. As you heard, my own career in academic public health blossomed out of my doctoral studies in communication. I mentioned that I worked as a journalist in the 70s. Some of you in this audience that are closer to my age will recognize that era is very different from the world of communication that we know today. It is the difference between the analog world and the digital world. And in 1978, I chose to pursue a doctorate in mass communication. And while doing so, I connected with the School of Public Health that was looking for staff with professional media skills to help create community intervention campaigns that were promoting heart health. Now, at that time, public health in the United States was recruiting social and behavioral scientists from many disciplines. It had begun to research large-scale community health promotion and chronic disease prevention campaigns. And the concepts of social marketing were being applied in public health, as well as health communication, social determinants of health, and so on. These frameworks had their basis in sociology, psychology, economics, political science, as well as communication and marketing. And for public health, this was a very important addition to what was becoming an increasingly multidisciplinary interest in health and well-being, not disease alone. So public health began asking the question, what makes us healthy and how can we promote it, in addition to what makes us sick and how can we prevent it? Two questions obviously have always been linked, but as you know, how we frame our questions shapes what we observe. So in a very short time, I realized that academic public health would be my home for the rest of my academic career, and it seemed to be a way to make a tangible difference in the lives of communities, population, nations, maybe even the world. And that brings us to the past 24 months and the challenges we face in the missions of public health. Public health experts warned us about such a pandemic for decades. Would the next big one echo the great influenza pandemic of 1918, or would it come from the equally concerning family of coronaviruses? They also warned that despite late 20th and early 21st century advances in science, health, and technology, the planet was woefully unprepared for a pandemic on the scale of 1918. Some advances, especially in travel, portended far more rapid spread of very contagious viruses. And several scares came and went. In 1997, H5N1, an influenza virus, first appeared in humans. Then SARS in 2003, another influenza virus in 2009, a variation of H1N1 related to the 1918 virus. Then MERS in 2012, yet another coronavirus. And between 2014 and 2016, the Ebola outbreak in West Africa, with the highest mortality rate yet seen in this class of hemorrhagic viruses. And SARS-CoV-2 beginning 2019. And every one of these began in an animal reservoir. In the first 12 months of 2020, we all watched the world turn upside down with astonishing speed. It followed the first electronic whispers of an unknown respiratory syndrome in Wuhan. We all have memories, I think, of major events that we recall, where exactly we were and what we were doing at that moment. In December of 2019, our school was celebrating its 75th anniversary with about 350 guests at a banquet. And the previously mentioned Dr. Michael Osterholm, whom you see here, took me aside and whispered in my ear, "This virus is highly infectious and likely to go global." And some of you may recognize Michael from his frequent appearances on national and international media during this pandemic. The SARS-CoV-2 virus traveled the planet, infecting nearly every nation between late December 2019 and September of 2020. An astonishingly rapid spread in a mere 9 months, it infected at least 35 million people, causing 1 million deaths. Few nations were prepared for the scale, scope, spread, and speed of change of this virus. It is relentless, as we have seen even in the last few days, as Delta variant cases are rising in many nations. But also astonishing were the scientific advances over the past couple of decades that made possible the rapid development of messenger RNA vaccines. According to accounts, a virologist in China first typed the sequence of the unknown virus and recognized the coronavirus signature and similarity to SARS. That was in January of 2020. The sequence was shared, and by February, the Coronavirus Study Group of the International Committee on Taxonomy of Viruses had named it SARS-CoV-2. By March 17th, a week after WHO declared a pandemic global emergency, the first human trials of a vaccine were beginning. And by December, vaccines had been approved for emergency use. And mass vaccination for those 16 years of age and older began and continues today with new recommendations for children 5 to 15. And additional booster vaccinations for those over 60 and eligible due to compromised immune systems. And this is where we are 12 months later. I snapped these data from Johns Hopkins University on November 3rd. Global cases have now passed 248 million, with more than 5 million deaths worldwide. Yet, more than 7 billion vaccine doses administered. And most epidemiologists agree that the case and death numbers are underestimates. The green line that runs through all three graphs shows the start of vaccination availability. Prior to that, the strategies available to us to slow the spread were containment and mitigation, and that is where we see big differences across the world. In the United States, for example, as in China and some European nations, Brazil and others, COVID-19 quickly overwhelmed containment strategies. And this includes, as you're aware, generally coercive and forced isolation, quarantine, lockdowns that prohibit travel in or out, with large-scale testing and contact tracing based on a zero-tolerance model for viral transmission. It worked for some nations initially, South Korea and New Zealand, for example. Taiwan's approach was successful, but in the 2020 period, avoided the lockdowns that were imposed by New Zealand. And there's a great article in The Lancet by Summers, Cheng, and Lin and colleagues in November of 2020, and it revealed why, and I quote, "Extensive public health infrastructure established in Taiwan pre-COVID-19 enabled a fast, coordinated response, particularly in the domains of early screening, effective methods for isolation and quarantine, digital technologies for identifying potential cases, and mass mask use. This timely and vigorous response allowed Taiwan to avoid the national lockdown used by New Zealand, and many of Taiwan's pandemic control components could potentially be adopted by other jurisdictions." That's a quote. As the virus has mutated to infect more rapidly, of course, Taiwan too has had to adjust its strategies to avoid overwhelming its healthcare system. So continuing vigilance and adjusting mitigation strategies is especially important for moving this virus from pandemic to endemic. Sadly, my country remains the world leader in total cases and total deaths. Yes, population size and density, as well as culture and governance, are important. The US has the third largest population in the world, behind China and India. By most accounts, China has done well curtailing the virus, but with continuing provincial outbreaks of the Delta variant and a strategy they now call the People's War on COVID. Despite a substantially larger population, India too appears to be doing much better than the US. And as of today, quite a few European countries are experiencing a fourth increase in cases, with a recommendation coming for a new lockdown. In the US, some 20 states in the West and in the North are again seeing rising Delta variant cases that threaten to overwhelm hospitals and health systems. And that, by the way, includes my home state of Minnesota, where we see a fifth spike in cases since the pandemic began. Main causes: unvaccinated adults, children who aren't yet approved for vaccination, declining immunity among the vaccinated, and less adherence to mask wearing and social distancing. And there are inequities too in the US across different populations. American, Indian, Black, and Latino populations are at greater risk of COVID. And there are also global inequities of low-income nations that have yet to receive sufficient vaccines for their people, especially concentrated in Africa. We are all asking critical questions. What went wrong? Why were we unprepared? What was missing for effective global and local response? Safe, effective vaccine development was a success, but equitable distribution, much less so. Containment and mitigation approaches succeeded in some nations, at least for a while, and failed miserably in others. What must we change before the next pandemic? And many epidemiologists and virologists believe we won't have to wait another century for the next one. And finally, what is our role in academic public health? Our discussion today cannot address all of the challenges that we face, but one good thing coming out of this predictable disaster is that already a global and local examination is beginning in earnest. As academic institutions of science and learning and public engagement, observation and critique is absolutely one of the important roles of academic public health. One question to ponder is, how do we better leverage this role on a global scale and scope? And more on that point in a little bit. In May of 2020, the WHO 73rd Assembly passed a resolution that established the Independent Panel for Pandemic Response and Preparedness. And they were to answer the question, what went wrong and what can the world do about it? It was co-chaired by New Zealand Prime Minister Helen Clark and former Liberia President Ellen Johnson Sirleaf, and also with a diverse international membership. The panel did issue its report a year later in May of 21, and this is a profound quote from early in the report's findings. Quote, "This pandemic has shaken some of the standard assumptions that a country's wealth will secure its health. Leadership and competence have counted more than cash in pandemic responses. Many of the best examples of decisive leadership have come from governments and communities in more resource-constrained settings. There is a clear opportunity to build a future beyond the pandemic that draws on the well springs of wisdom from every part of the world." Now, if you read between the lines of that quote, greater global collaboration, sharing, decisive, competent leadership development offers a context for creating a better future. Yet the report acknowledged that the public record for this has not been positive. The Global Health Security Initiative and the Action Group, begun in 2001, had many members worldwide, but few commitments to solutions. 2016, the Commission on a Global Risk Framework for the Future noted that its proposed spending on preparedness of a few $billion was a mere fraction of what a truly global pandemic would cost the world. As the pandemic began, the world struggled to control it. The independent panel identified an important context quite different from the 1918 influenza pandemic. Two worlds operating at distinctively different speeds. The digital world of our century provided rivers of information from multiple sources within which analysts could read the signature of a potentially contagious respiratory pathogen. Incidence reports, epidemic surveillance, social media, exchange networks, all digital. Yet the world of governance, even with the flow of such information, functioned much more slowly, leading to decisions and actions. As the panel observed, such processes often focused more on what shouldn't be done rather than what should be done. Two worlds, different speeds. The virus, of course, functions at a faster pace. And as the panel noted, we have failed in our collective capacity to come together in solidarity to create a protective web of human security. Now, it may be tempting to think that autocratic nations compared to participatory democracies have an advantage here, but the evidence is not supportive. All autocracies and democracies certainly are not the same. Currently, Russia is in trouble. So is Turkey, Brazil, and North Korea, among those on the autocratic side. China has done reasonably well. On the democracy side, the USA response initially was the worst, and we still are experiencing the fallout from that. And the United Kingdom and some European countries are not doing well. Yet Taiwan, South Korea, Argentina, and France are among those doing better today. A recent article appearing in the online journal Frontiers of Public Health by Sora Lee and Ryan Wong discusses South Korea's COVID-19 response in terms of hybrids of governance modes. As the authors stated, it would be productive to think beyond the oversimplified understandings of governance modes and embrace flexible and different hybrids of governance modes to be more responsive, effective, efficient, and equitable. This is the lens of the whole society approach, engaging all sectors of a nation, public, private, and civil society. Point is really important. Neither autocracy nor democracy in themselves guarantee competent, decisive leadership, adequate public health funding, global collaboration, sharing of information, or equitable investment in resources, including public health systems. That requires a level of global cooperation and collaboration that we need to achieve for that future in which everyone thrives. This is by no means a new insight. We have been discussing this for a couple of decades at least. This quote from Dr. Gro Harlem Brundtland, who served as WHO Director General from 1998 to 2003, makes these points. Whether globally or locally, we may say that the approach is this: we will all do better when we all do better. Following up on the independent panel recommendations, the 74th World Health Assembly has planned a special session for November 29th through December 1st of this year, just around the corner. The topic is a pandemic treaty, and this is a proposal that they would like to make binding on nations. And this would address the challenge of a more coordinated global response to the next pandemic, as well as the inequities that exist between rich and poorer nations in access to vaccines and treatment drugs. For the first time, by the way, the US has indicated its support for a temporary suspension of intellectual property rules to encourage wider production of vaccines and treatment drugs. One concern, of course, among skeptics is that the world avoid creating another international bureaucracy that could slow an effective response. As the global and local process of examining what has gone right and wrong during COVID continues, questions have been raised about public health itself. Is it a victim of the pandemic? Is it the author of its own failures? This discussion is different across national contexts based on governance structures and national cultures. So I'm going to focus my remarks here on what I observed in the United States for two reasons. One, it's my home. And secondly, I'm sad to see how such a poor response to the pandemic in one of the richest nations in the world has left us with the largest burden of infections, disability, and deaths. That's wrong. And let me say up front that the answer to both questions, is it the victim of the pandemic or is it an author of its own failure? The answer to both is yes. Public health is both a victim and it's also responsible for its own failures. But there is lots of blame to go around, especially in the United States. And the discussion is beginning to focus on the most important question: where does it go from here? In the public health as victim discussion, the reality is that the US has an extremely decentralized, disconnected set of separate systems at local, state, and federal levels that may or may not even connect with one another effectively, let alone with state and federal agencies. States have the primary authority to address public health, and local public health is subject to different governance structures at the state and local level, including county commissions, city commissions, and state boards and departments of health. Now, to be sure, there were federal agencies, including the US Public Health Service, that could have taken leadership when COVID appeared in 2020 during the Trump administration, but they did not do so. No plan for containment, no plan for mitigation, and this left states and local public health to fend for themselves. And the Centers for Disease Control and Prevention and the National Institutes of Health spent their time offering guidance and recommendations, although it is true that Congress did support states and local public health with funds. So by the time a national emergency was declared, containment was essentially not possible. And coordinated plans for mitigation did not exist except as hastily constructed by state and local responses. The simple fact is that governance at the national level failed and the infections and the death toll mounted rapidly. One positive thing that the Trump administration accomplished in this period was mounting Operation Warp Speed, leading to the manufacture of the messenger RNA vaccines. But when they were ready for emergency use, there was no plan in place for public education and distribution. And at the time, President Trump was obsessed with overturning a legitimate election that voted him out of office, and so no plan was ever produced at the federal level until the next administration came on board. So the public health disaster of the US initial response to COVID was not entirely of the Trump administration's making. In a post-mortem analysis of what went wrong, the Lancet Commission on Public Health and Policy had this to say about US history, politics, and culture that created the root causes. A 4-decade-long drift toward neoliberal policies bolstered corporate prerogatives, privatized government services, reinforced racism, and imposed public austerity. The rich got much richer while their taxes were halved. Workers' earnings stagnated. Social programs shrank. Prison populations greatly increased, and millions were priced out of health care, even as government payments enriched medical investors. Gross domestic product grew, but longevity lagged, a sign of profound social dysfunction. That's the report of the Lancet Commission on Public Policy and Health in the Trump era. While the disaster's first public health response was decades in the making, there is that other dimension to explore. Was public health in the USA author of its own failures? And that point of view was best expressed recently by science writer Ed Yong in the Atlantic Monthly magazine, who wrote about how public health took part in its own downfall. Yong's article benefited from many sources, interviews with academic public health folks and those in public health practice. So the basic thesis goes like this. US public health was very successful in the 20th century at extending lifespan, reducing infant mortality, infectious disease, and raising success in other public health domains. A statistical analysis of contributing factors concluded that US lifespan from 1900 to 1999 increased by 30 years. About 25 years of the increase were due to public health measures in sanitation, hygiene, and disease control, while the remaining 5 years were attributed to improvements in medical care and treatment. Now, some historians believe that US public health had become complacent, forgetting its early 20th century advocacy roots that pushed change in social and working conditions that caused disease and lifelong poor health in the first place. And as the Lancet Commission suggested, public health in the US may have bowed to the rightward political conditions that led to widespread state disinvestment in two major institutions beginning in the 1970s. The first, public health disinvestment. The second, higher education disinvestment. We've been suffering from that ever since, and the ongoing cycle of public health, panic, neglect, repeat, as described by former World Bank President Jim Yong Kim. Most troubling of all, at least half of the US states dominated by the Republican Party are seeking legal changes to tie public health's hands in the US from responding effectively to future public health challenges. Before we move into what we in academic public health can contribute to addressing the many challenges we face, I want to say a few words about public health and communication in the COVID era. I think this also bears on what we as academic public health faculty must consider for the future. In this pandemic, public health was blindsided and overwhelmed by a continuing flood of misinformation and disinformation about this virus and its prevention and treatment. Some have rightly called this an infodemic. Much is about individuals sharing information with friends and family, but much more is about extremely well-organized groups weaponizing social media with falsehoods and conspiracy theories. The purpose is to undermine trust in scientific evidence, public health, medicine, and public policy, and to recruit social media users to do it for them. For example, in May 2020, a very slick Hollywood-style documentary appeared on the web called Plandemic. It claimed that COVID was planned by global elites to control the world's population. Vaccines were dangerous, masks activated the virus, and science and scientists were part of the conspiracy. And it also pushed people toward extremist politics of the right. The authors of this documentary anticipated that their work would be removed from some social media platforms, so to assure continuing spread, they urged viewers to download the documentary and share it with their own networks. Now, by the way, the Johns Hopkins School of Public Health Center for Health Security today estimates that misinformation and disinformation costs the United States between 50 and 300 million US dollars. And that is about illness and deaths of real people in those numbers. I've included on this slide the citation of a superb study by Nazer and Peters, published in September, that studied this disinformation campaign in great detail. It's an important work for public health because it also addresses some techniques to counter disinformation. And where will public health professionals and scientists learn to counteract this, if not among the subjects that we teach in schools and colleges of public health? And that is a good segue into a discussion of what we in academic public health should be doing for the future. What should we be contributing globally and locally with respect to our missions of research, learning, and public engagement? Considering our expertise of the past, of our experience, I should say, of the past 2 years, what have we learned and how should it shape our missions, especially as the current pandemic becomes endemic? Academic public health provides the main institutional network of scientists creating new knowledge, shaping that new knowledge into learning, teaching, and professional public health practice and policy, and engaging with the people to make everyone's lives better. What is different about the work we do is the idea of ecology, the relationships of organisms to each other in environments that provide conditions and forces shaping interactions. This is true of humans as much as it is true of viruses. What happens in front of our eyes today is the product of this complexity upstream that created conditions for what is happening now, for good or bad. Our public health forebears of the 19th and early 20th centuries knew this. Living in poverty, racism, lack of safe housing, education, opportunity to thrive, all of them combine to shape our relationships and our health and well-being. you know this well, Taiwan is one of the few nations that over time has dramatically reduced deep poverty, but so many others are far from it. And in a larger global ecology, the actions of others far away from us shapes our future health and well-being. Climate change, for example, as we are once again reminded by the Glasgow COP26 summit. Global is local, local is global. Most public health challenges are like an onion. There are many layers, and each one is related to all the others in some way. It is one world, one health, whether we like it or not. And this is a challenging view for a lot of people to understand. In the case of infectious disease, including what we've experienced since 2019, we are reminded again that some 75% of newly emerging pathogens affecting humans come from animal sources. And with climate change, the emergence and spread of new pathogens and the resurgence and spread of known pathogens are an enormous public health concern. First point, because of the missions of academic public health and the global and local ecology of the challenges we address, we must continue to strengthen our global system, the Global Network for Academic Public Health. This was officially established by the 7 regional networks of schools of public health that are listed here in May 2020. That was barely 60 days after COVID was declared a global pandemic. And although it is in its infancy, it's an important advance in shaping the global public health agenda for research and education of next generation public health scientists and professionals, and for engaging with leaders and decision makers about public health challenges. Its potential power is in synergizing our institutions and revitalizing our missions through global and translational thinking, true partnerships across sectors, interconnected systems of which academic public health is one, and informing leaders and decision makers in shaping solutions. Of course, academic public health went global more than a century ago, and yet the idea of synergizing is far more recent, enabled in part by the founding of the United Nations and the WHO after World War II. Quite a number of schools were called on during and after that war to strengthen public health worldwide. My own school's contributions during and after the war were studies of human starvation that helped create the protocols for rehabilitating concentration camp prisoners and other starving people back to health. And in the early 1950s, our founding dean, Gaylord Anderson, was asked by the US State Department to develop a school of public health in collaboration with South Korea following the armistice. Seoul National University's School of Public Health was the result of that partnership and collaboration. This map that you see here shows our school's current global research collaborations across the globe. But schools like ours come from a rich nation, and there are many in much poorer nations that struggle. And I think one of the challenges for the global network will be the problem of equity in academic public health across the globe. How do we address capacity building in partnership without creating a new colonialism of rich nations? Second point, this is about our education and training role in both public health science and practice. There are many groups for our teaching in addition to our students. One is continuing education of the professional and science workforce through the idea of lifelong learning. But there's also just-in-time learning in response to sudden public health needs. There's also the need to educate all the health professions and beyond them, other professions, leaders, and decision makers. We need leaders who understand the basics about public health, evidence, risks, decision options. And the global network, I believe, offers us an opportunity to share this worldwide in many different languages and cultural frameworks. Could we develop an everywhere, anytime, just-in-time cooperative learning platform with a global reach? I hope you're intrigued by that idea, and I'm guessing that there must be 1 or 2 billionaires out there in this world with the money to really help make it happen. Such a global cooperative network might also be established with respect to public health data science and analytics. Several of our faculty worked with our state in modeling the spread of COVID infections, in part to calculate the point at which the healthcare system would be overwhelmed, but also to follow infection rates and deaths. Now, this is an emerging field in which large-scale global sharing, partnerships, and collaborations would be of great help in response, containment, and mitigation in the future. And I am very aware that Taiwan has expertise in this area. These areas that you see listed here are a few of the content and competency domains that I believe are needed more than ever in public health. Understanding and practicing good leadership at the top is a must, whether you are a professional or a scientist. Design thinking borrows from architecture and engineering with a process laid out here that encourages innovative thinking and solutions. We need that in public health, new approaches that we can research, test, prototype, and refine. And I am aware very much that design thinking is right here in Taiwan as it is in Minnesota. The third point, this is about the public in general. As I said earlier, and it bears repeating, we must do a far better job of communicating with the people what public health is all about. As we know, so many do not understand how it works in science, evidence, practice, and systems. Science and scientists are no longer automatically granted the deference of expertise that they once enjoyed. And traditional media, such as newspapers, magazines, radio, and television, have also lost much credibility, overwhelmed by the echo chambers of social media. And as we discussed earlier, blindsided by well-organized purveyors of misinformation and disinformation. And as we have seen, people's lives are at stake. Building and restoring trust is a major issue for us in public health worldwide. Somebody once said, we live in an age when falsehood goes round the world 3 times before truth puts on its shoes. And with that, ladies and gentlemen, I say thank you for your attention, and I look forward to our discussion. Thank you, everyone.
Thank you, Professor Finnegan, for the wonderful and insightful lecture. The organizing committee and the board of the foundation would like to express our deepest appreciation to Professor John Finnegan for the lecture. We would like to invite the Dean of NTU College of Public Health to virtually present the plaque to Professor Finnegan. 请院长暂时脱下口罩，这个符合防疫规定。Let's give a warm applause to celebrate being a part of this historic moment. Next, I would like to invite Professor Chen 陈前院长一起join 这个 photo shoot。院长也请您暂时脱下口罩。对。 院长，请您坐。Thank you, our respected deans. After such a wonderful talk, we will now take a 10 minutes break so the audience can exchange further thoughts. If you have questions inspired by the lecture, please kindly let us know during the break so we can incorporate them into the upcoming discussion session. We will resume the session at 10:20. Thank you.
个副院长说他会想问你。 现场的贵宾，时间差不多了，请您回座，谢谢。
最重要是防疫意识啊。SARS 结束最重要的一件事情就是防疫意识，才有楼一间。没，CDC 我是第一任局长，那个是长病毒之后，那是长病毒之后，对，啊，长病毒之后遇到 SARS 就垮了，啊，所以 SARS 之后就是有防疫意识，这个最重要的一件事。
各位贵宾，我们再稍等1分钟。那因为我们可以维持社交距离，是不是请2位院长可以脱口罩？谢谢。Okay, welcome back, everyone. We will now continue the next session. We are honored to have Professor郑守夏, Professor陈为坚, and Professor John Finnegan as the discussants. Let's welcome Professor John to host the discussion session.
Okay. Welcome back. First of all, I would like to invite Professor Weijin to give a short presentation about Taiwan's COVID-19 situation and the response to the pandemic as a supplemental information for our further Q&A session. So please go ahead, Professor Chen.
Okay. First, I'd like to thank Professor John Finnegan. You have outlined a very comprehensive landscape about the impact of COVID-19 on public health in general, or public health education in particular. And as you said in your talk, the impact on each nation's public health is really context dependent. So now I'd like to use the situation in Taiwan to see how public health educators in Taiwan use this pandemic as an important opportunity to accomplish an advocation have been more than 20 years. That is, we have the first Asia's Public Health Specialist Act passed in last May. And that's totally triggered by the pandemic, because at the early stage of the pandemic, Taiwan government quite successful in containing the spreading of the SARS-CoV-2. And the general public really appreciate the effort, conducted by public health professionals. So that create a very important opportunity. So all the congressmen across the party, they support the path of the public health specialists. And this Public Health Specialist Act have two very important aspects. First one, it not only creates a formal slot for government to employ public health specialists using government slot, but also create a new frontier for public health specialists to open their own business office and conduct it in private sector. So I think this opened a greater field for public health specialists, okay? And also, it had a lot of regulation saying, you know, in what kind of situation you can open an office. So this will really create a new opportunity for younger generation in public health specialty. So this is the first important aspect. The second one is what kind of subject to qualify to be a public health specialist, right? And fortunately, because NTU participate or try to apply for the CPH accreditation, so we learn the public health education component. So we try to build the subject matter on that foundation. So eventually, the examination end, posted the sixth subject to be the examination for public health specialists. And the first subject is health regulation and ethics. So this is quite a new one because as John, you being the board director of the ASPPH, right? And so in our core competence, ethics is not the separate one. But for our examination in Taiwan, they put health regulation and ethics as a separate subject. The second one is biostatistics. The third one is epidemiology. The fourth one is health administration and management. And the fifth one is environment and occupational health. And the sixth one is the health and social behavior. So you should be proud because, CPH or the ASPPH framework really help people in Taiwan to convince the government it's feasible and practical to have a specialty examination for public health specialists. So I think this will have a very long lasting impact on our future public health education as well as our public health infrastructure. And before that, I also like to point out why the pandemic became a trigger for our success in pushing the path of the public health specialists. It really stems from our global collaboration. When I was teen, in 2012, I served in from 2011 to 2017, and you probably remember I flew to San Francisco to see you and invite you to come to NTU to host our academic evaluation. And through that process, we also have the chance to invite many people from ASPPH to come to Taiwan. And one important member is our former CEO, Harrison Spencer. And he told me one story. He said, when he became a CEO, he tried to push a certification in public health. So they started the examination in 2007, and he volunteered to take the exam in the first year. And fortunately, he passed the exam. Okay, so that's 2007. And at that time, we already in the process tried to convince the government the importance of public health. But they continue to have some doubt. Is public health really an expertise, right? So at that time, I also served as the president of Taiwan Public Health Association. So we adopt Harrison's approach. So we set up a national examination for core competence in basic course in public health. So starting from 2009 to 2019, we have 11 years of annual examination, and more than 4,000 students, took the exam. So because of this work, we successfully convinced the examination unit. So they agree before the passage of the act. Once the Congress passed the act, they agree to hold the national examination because we provide the data. So I think this one example, important public health education idea can be shared, and each people can use the concept and under the context of the nation, try to advance public health. So I think through this pandemic, the infrastructure of Taiwan's public health is expected to be reinforced because in the new generation, all the public health specialists, they will educate, about the all core competence as advocated by the ASPPH. So from this point of view, I think this pandemic really helped Taiwan to move the public health infrastructure to the next stage. So I just like to use the example to illustrate how to capture the opportunity and try to reinvent our public health education. Thank you.
All right, thank
Thanks
you very much,
very
Weijin, sir. Dean Finnegan, can you give some feedback?
I just wanted to make a couple of brief comments on that. First of all, congratulations on being able to get that Public Health Specialists Act passed. And it intrigues me because you're making an effort to cross into private sector as well. And I think that's going to be critical when it comes to public health. It can't be just government. It's really got to engage, the public and the private sector working together. One thing that we've seen in the U.S., medicine tends to dominate very much. And we have seen a movement which is called the Practical Playbook movement. And it's an effort to bring primary care medicine and public health more closely together. And rather than be rivals, but because primary care tends to have many of the same values, I think that public health does. So that's one movement to really, I think, bring those professions together rather than as rivals. And then the other thing I wanted to say is that you're to be congratulated on putting ethics right up at the top. When I started as an associate dean for education at Minnesota, I realized that ethics was nowhere in our curriculum at the time. And in fact, I don't think there were any U.S. schools that were really pursuing ethics as a specific subject area. And so that was one of the proposals that we made. I think we were one of the very first schools of public health in the States to adopt ethics. And we tended to split it up so you could do a course in practice ethics and a course in research ethics. And but I think that achievement is so important to the future of public health that ethics be right there and up front. So thank you very much for those remarks. It's very good.
Okay, thank you, Dean Finnegan. Now we have a couple questions raised by our faculty members. The first one is, let me invite Xianhe, Professor Lin Xianhe. Yes.
Hi, Dr. Finnegan. My name is Xianhe Lin. I'm from the Global Health Program and the Institute of Epidemiology and Preventive Medicine. Thank you very much for your wonderful talk. I have one question, maybe following the Professor Kp Chen's comment on the public health specialist is about the issue of surge capacity of public health workforce. And as you must be aware of, we saw this need of a rapid increase in public health workforce during the pandemic, not just, for example, in the United States, but also in Taiwan when we were facing this past outbreak in May. So I would like to borrow from your insights on how we can better prepare or strategically think about different ways so that we could be better prepared when there is a need for such a rapid increase of public health workforce. Thank you.
Oh, that's a terrific question, Professor. I would, we have a little bit of experience with that. So this goes back to about 2004. And in the States, you may remember that there were two hurricanes that hit New Orleans in the southern United States, like within a month of each other. We had formed in our state something called a Medical Reserve Corps. And it was composed of academics, physicians, nurses, pharmacists, medical students, public health students. And it was for exactly that concept of a surge, when you need to deploy a large number of people in a very short period of time. And we've kept that. It's called Medical Reserve Corps, but it's not just about medicine. It's got all of the health professions present. And also the Mayo Clinic and some of the other universities in Minnesota joined with that as well. So that when certain major disasters occurred, we've had floods. We deployed 4 times to Louisiana during the disasters there in 2004, and we've kept it up to this day. That's one way to look at it. I think you've put your finger on a big problem, which is, all governments are concerned about cost and, how much surge capacity do you maintain over what period of time? What can you afford? And that's been one of the problems with the healthcare system that we've seen in the US. And this is happening in many other countries. This virus is so potent that the infection rate happened so rapidly that many healthcare systems were just overwhelmed. And so even if you have the people, you may not have the facilities, and that's the other part of this. But there are discussions going on about what do we do in light of this. Should we have another pandemic similar to this? Are there things that we can do to maintain facilities that could be rapidly deployed if necessary? I won't say that we've solved that problem, but at least on the workforce area, this concept of a medical reserve corps has been very, very helpful in a variety of different ways. And it brings together people with communication skills, with pharmacy skills, with nursing skills, and so forth. So great question, and one we're going to all have to work on.
Thank you very much.
Okay, thank you, Dean Finnegan. We have next question raised by Susan, Professor Zhang Susan. Yep, please.
Thank you for your wonderful speak, Professor Finnegan. I'm Zhang Susan. I'm with the Institute of Health Behavior and Community Sciences at the College of Public Health. And when you travel to Taiwan in 2019, September, just a few months before the pandemic began, I have the pleasure to sit next to you on the coach to when we travel to Changhua County. Yeah, it's a very busy day, and I really enjoy the conversation with you on the coach. And thank you for sharing your experiences and insights with public health. And just follow your comments about the potential and actual contribution of social sciences in public health. You mentioned that over the last few decades, one important development within public health is to bring expertise from social science, including community sciences, sociology, psychology, and anthropology. And at this in this college, we are also bringing in new expertise in those areas to our school. For example, in my institute, we have faculty members trained in anthropology, community sciences, behavioral sciences, and mental health. And I understand that your expertise is in the area of community sciences, and which is critical in the battle against the pandemic. You mentioned about the challenge of infodemic. And in Taiwan, we also have similar challenges. For example, in last year, we have a lot of controversy around the true incidence of COVID in the community, and also debate around massive screening. And this year, we have debates around the safety and the effectiveness of different brands of vaccines. So this contributes to vaccine hesitancy. And this is also our one of the critical challenges we have faced. So could you, based on your expertise and experiences in community sciences, could you share a bit of insights about how public health can contribute to the communication about public health interventions, and also addressing the infodemic challenges in the pandemics? What kinds of expertise and toolkits and also frameworks we can use? Thank you.
That's a very big wish list, and thank you for asking that question. I really do believe that when the social and behavioral sciences in the U.S. started to move into public health, it really changed a lot of people's perceptions. And certainly me as a social scientist coming in to a public health environment, that environment changed me. I could walk down the hallway and talk to an epidemiologist. I could talk to an educational psychologist, and it was amazing. So I think the direction that public health is moving in is what I would call transdisciplinary. So we're making new knowledge, if you will, that bridges a lot of disciplines. So it's not just lots of disciplines working side by side like children in a sandbox. It's actually creating something, I think, that's new. On the issue of communication, when I started working in public health, it was just on the cusp of an explosion in communication systems around the world. So this would have been in 1980. I had just finished a career as a journalist. And in 1980, we suddenly had CNN emerged, satellite news. And that began to break down regional borders of media systems and state borders and things like that. Now, of course, everybody has that megaphone of social media, and the rapid speed with which misinformation can flow all over the place and all around the world is really doubled. This is an area where I really believe reaching into the private sector and forming some relationships in the region of communication, working with social media outlets, working with public relations, communication firms, really offers an opportunity to, I would say, reach people in a different way. I'll give you one example. We just finished a study in which we were encouraging people to use baby aspirin, 81 milligram aspirin, if you're of a certain age and so forth. And we did it in Minnesota, and we used essentially social media, because no matter whether the audience was older or younger, everybody was using social media. And we were able to work with those planners, those analysts, on developing a strategy with social media that could instantly be shifted and changed to be more effective. So I think that's one of the things that needs to be done, is to work more with the digital content producers in the media world, the social media world. That's one way, I think, of dealing with it. The other thing is that during COVID, our health department in Minnesota was having enormous issues with mostly people in the rural areas of Minnesota, I would say, not so much the cities, but the rural areas. There was a lot of hesitancy about vaccine and conspiracy theories and things of that kind. And so I was contacted by the commissioner of health, and I managed to put together a team of people from across the university, not only in our school, but folks that also were in the other health science and departments. And so we were able to work with them and design what we hope will be a much more effective messaging strategies, and then how to reach people. So I think what I'm arguing for is that this process of taking public health to the civil society sector, taking it to the private sector, working in conjunction with the public sector, I think we have to do much, much more of that. I know we do in the US, and it sounds like you are beginning to break down some of those walls here too. Thank you. Great question.
Thank
and
you.
Much more to talk about.
Yeah, well, it's not, there's no easy answer to this behavior-related actions or policy, I think. Okay, our next question was raised by Professor Fang Qi-tai. So please, Dr. Fang.
Dr. Finnegan, thank you very much for the great lecture. I'm Qi-tai Fang from Institute of Epidemiology and Preventive Medicine. I have one question. As you just mentioned in your lecture, it is very sad that some people use a digital platform to spread incorrect information on this pandemic. Actually, we observed the same phenomenon in Taiwan. And because you are an expert on the communication in public health, so I would like to know, in your opinion, the academic public health, how can we help to mitigate the negative impact of this infodemic? Thank you.
Thank you very much. I wish I had a magic wand that I could wave over the problem and make it go away. But I will say this, we have to get as organized and as planful as those groups. And I think, where we were blindsided is that when this all got started, we just make assumptions in public health. Oh, well, of course everyone will want a vaccine. Of course everyone will wear a mask. Of course everyone will social distance and so forth. And it isn't true anymore when you've got groups of people that are so well organized, and I mean very organized. So if we're going to do this effectively, it can't be amateur hour. It's really got to be professionalized. And I would say right now there's a couple of efforts. I know Johns Hopkins has put together a health security center. And that is really an interesting one because some of what they're doing is getting information on who are the biggest spreaders of disinformation and misinformation. And the point is that if you want to counteract them, you need to know who they are, what they're doing, and if possible, if you can, from a communication standpoint, you may be able, there is an old theory in communication which actually has pretty good science associated with it. It goes back to the 1950s. Believe it or not, it's called inoculation theory. And so it's based on the whole concept of vaccine. And where it was originally tested in my world was in the area of working with children to fully inform them about what tobacco companies are trying to do when they advertise. And so if you work with young people in that setting, and I think it works with adults too, if you can get to them first, and I would say in the next pandemic, that's one of the things we need to do. We need to get to people first and say, look, there are folks out there that are going to come and tell you lies. They're going to come and tell you this, they're going to come and tell you that. Don't believe it. And it's not just that simple. Obviously, we need to do a lot more in terms of rebuilding trust in science and helping people understand it. But the whole concept of inoculation theory is that just like vaccines against viruses, that if we can get to the audiences early or first, then we can plant the seed that there are others out there they're going to hear from that do not wish them well. And so I would say that's not the only approach, but it is one approach. And as I say, that's why I think we need professionals to help out.
Okay, thank you. Actually, in advance, we have a question raised by our student. They're sitting in the other room watching the same screen. And perhaps Professor Weijin can do the help.
Yes, it will be my honor. As we mentioned before, COVID-19 pandemic has reshaped the way we communicate, and this conference is a living example. In today's hybrid conference mode, we have set up different rooms for the other audience to participate so we can keep adequate social distance. On behalf of our students and faculty members, I would now present a few questions. The next two questions are from Ms. Huang Zhenyi, an undergraduate student from the Department of Public Health. Her first question is, let me quote, how does Professor Finnegan think public health and citizen science can be integrated? Can you give us some examples? And second question, in terms of current issues, COVID-19, do you think there is any citizen power in the community that can collect information or take actions that can help stop the spread of the pandemic? Are there any medical ethics involved or other problems encountered so that we cannot rely on the information collected by citizens? End of quote.
Oh, wow, good questions. I would say the answer to that is yes. I do believe that citizen science is important. I can give you a little bit of an example of that. When we in Minnesota were dealing with the first big spike, the state health department needed lots of people to work on contact tracing. And we still had a belief that we could do some containment with the contact tracing. And so we had, at any given time, I would say about 50 to 70 of our students are working with the state health department in one way, shape, or form. And they also brought on some undergraduates as well, and volunteers. And so I think the whole concept of a volunteer network being engaged in this is really, really important. Outside of COVID, I can tell you that I had an experience in the Antarctic, believe it or not, with citizen science. I went down there and they were doing it was a cruise, but in a very small boat, and the focus of the cruise was really kind of citizen science. So one of the things that we ended up doing was sampling for krill in the Arctic waters, and then that would be counted in the microscope, and then the data would be transmitted back to the Scripps Center on the West Coast. That was fascinating to me because the reason they were looking at krill is because if krill population were to collapse, everything else collapses. It's a food chain. And so that's what they were looking at down there. So I've participated as a citizen in citizen science. And I think that is a movement that we really need to involve. And here's part of the reason for that. We have seen a degradation of trust in expertise. So as I said in my talk, expertise is not automatically deferred to. And so I think the whole issue about engaging citizens in these kinds of things is really important. Our medical school, for example, does what's called the mini medical school. And you wouldn't believe how many people want to come to that mini medical school. The public, I mean, these are not necessarily people with college degrees all the time. Many are, but I think that whole area of engaging the public in that kind of fashion is really something that we can do a lot more with than we have up to this point. So, excellent question. I want to say one other thing, by the way. Those of you students who I guess we call you Gen Z, you know, every generation has a name, and I know that we're seeing students coming into our school that are in your age bracket, and I am so pleased with their sense of wanting to make the world a better place and of their passion for public health as one way to do that. And so please keep it up. We need more folks like you.
Okay, thank you very much, Dean Finnegan. We only have a couple minutes left, so I'm leaving this privilege to Professor Weijin. Do you have any further question for our discussion?
John, I think one important issue arising from this pandemic is how to maintain a good interface between academia and public health system. Because, you know, in the past, many schools of public health pursue excellence in research. And so under that kind of context, people are more willing to spend effort or energy pursuing some research-oriented topic. But for the government, sometimes they just like to ask scholars, for example, to back up their proposal. So it seems to me sometimes the relation between these two worlds is a little bit tense. However, through this pandemic, we find both parties need to have a very close collaboration. Yeah, and sometimes even government needs some early warning from academic. But how to, you know, make this thing happen? I think it's very challenging, particularly when I read from the news report. For example, one public health expert, you know, from the Johns Hopkins, and she went to serve as commissioner for public health in some state. But when she went to explain the vaccination program of the U.S. Government, and then some people, threatened that they may look for her address, so she needs to be escorted by police to leave the auditorium. So in that situation, I can imagine many people in academia will be afraid or refuse to serve in the government, right? And then that will create a more disruption between these two worlds. So I think that's really a very challenging issue. So I just like to take this opportunity to ask what's your observation, and do you have any recommendation?
We thank you for that. We have experienced some of what you just described. So we have a relationship with our State Department of Health, and that relationship, many of the people that work in that department were trained at our school, so that's a plus. At any given time, we have quite a number of our students that are doing internships or field work with that health department. And one of the things I've been working on discussing with our commissioner over the last several years, in fact, before even COVID happened, was how do we form a connection, a relationship with one another in which our faculty, with the expertise that the health department needs, can work with the health department and their folks, many of whom have doctorates and so forth, that we trained, can work with us in teaching next generation. How do we build that two-way, flow? University of North Carolina, Chapel Hill, I think, has a wonderful model for that, and the legislature of North Carolina provides funding for this, and so that school, I think, has I would call it the top end model for how to do this, and I think it does have tension, as you say, because the world of the academy and the world of government public health do tend to have some different rules and regs and so forth. But I think those things are bridgeable. So whether by public health institutes or by master contracts or other things along those lines, that would allow that closer relationship. The other thing is that we have spent much more time focusing on workforce development. And so we do a summer institute every year, and we try to keep the tuition down for public health workers, but they need constant updating of their skills, of their competencies. And I think that kind of a relationship is also one that tends to build much more trust between government and the academy. We also worked with our health department on modeling, because they had maybe one person who knew enough biostatistics and analysis that, maybe more than one, obviously. But that was a very useful initial effort for us, was to help them design the models that was helping to guide the governor in making decisions about this. So I do think that this is an area that needs a lot more development, but it is one that I think can be very productive. And I think there may be an appetite for this, given what we've been through with this pandemic, and recognizing that another one could be happening too. But thank you, great question.
Okay, thank you, Dean Finnegan. I think the Q&A section, the time is up, so we move to closing. Wanzhen, please.
Yes, thank you everyone for the inspiring discussion. We're now near the end of today's event. It is once again our honor to invite Dean郑守夏to give the closing remarks.
Okay. Thank you again, Dean Finnegan. Thank you for accepting our invitation to deliver the Kp Chen Memorial Lecture this year. And thank you for Weijin and our distinguished guests and our colleagues and students here. Thank you very much for attending today's event. Thank you very much. Thank you.
Thank you. It's my pleasure.
Before we officially close the ceremony, I would like to express our most sincere appreciation to our staff, who have been working so efficiently together as an amazing team, and then they have been on site with us all this time. In closing, we thank you for your participation to make this event memorable, and I wish all of you a warm winter and looking forward to seeing you in the next Kp Chen Memorial Lecture Series. Thank you. Okay. So the ceremony has officially ended, but now I would like to invite everyone for the photo shoot, but in sequence. Yes. Professor Finnegan, please give us a couple minutes to arrange the position. First, I would like to invite 请现场的同仁可以帮我们先撤椅子。那是不是请各位来宾以及老师先起立，然后我们稍后一下。我们请拱北基金会的董事，来到前面入座，谢谢。也请各位贵宾可以先暂时脱下口罩，这都符合防疫规定。Okay, Professor Finnegan, we'll have the first photo shoot. And next, I will please remain seated, please. Next, I would like to invite all the faculty members to stand behind the chairs in a row. 老师们，请站到椅子后方，排成一列。也请老师们可以暂时脱下口罩。老师，请。可以吗？
就是请中间的，就是左侧要转向，右侧要转向。
那我们是不是请国标老师为中心？请国标老师为中心，然后两侧的老师可以站45度角。张副老师可以请您再进来一点吗？Okay, ready?
Ready. Take one. Let me take two. Okay, take another one. 1, 2, 3. Okay, the last one. 1, 2, 3. Okay, thank you.
Thank you all, and thank you, Professor Finnegan. So this will conclude today's ceremony. Yes, and then you can now exercise your right to disconnect.
Thank you.
对对对对，
主持的非常好。
是然后let's wave goodbye to Professor Finnegan. To the camera everywhere. OK， 好，现场的贵宾们，我们还有一张大合照，请您移步到后方的位置。我们先请拱北基金会的贵宾入座。杜老师，国标老师，请。